Prakash sir is here.
Take him in.
Good evening, sir.
Welcome, Dr. Nayak.
Pleasure, sir. You know, you look exactly the same in your picture as you do live.
Ha ha ha.
So,
I have. There's no. So I don't. How can you see me? Like,
So we're all set. Pleasure, sir. You know, you look exactly the same in your picture as you do live. So why is it echoing?
And I'm just playing it back from the YouTube channel. Sir.
Oh, all right, okay.
oh,
I think if we are ready, then admit all.
Yes, sir.
Speak to Ashok.
Yes, yes. So you are the host again.
Okay. I need to make it.
We are streaming live, sir.
yeah.
We are ready to go, sir.
Okay. So 1 more minute. We'll start sharp at 6.
Why is Harsha in the background?
Should I begin? Oh.
Great. Welcome everyone, and thanks for joining us for another episode of TMH OrthOnco classes. We have been successfully doing these teaching sessions from past 2 weeks or so, and we have got amazing response. So thanks to all of you who have been listening to us on Zoom as well as on YouTube as well. Today's session is going to be a nice lecture by Dr. Devesh. He's going to speak to us on a role of radiotherapy in soft tissue sarcomas. My pleasure to welcome my colleague, Dr. Prakash Nayak, who's going to be moderating this session, and I'll be coming in between to help out. So we're going to have this lecture. In between, we will have Dr. Nayak making it a bit easy for you so that you can understand. And maybe at the end of the lecture, we will have some case scenarios where we can discuss the role of radiotherapy and different modalities and can discuss the questions as well. Dr. Nayak and
Thank you. Thank you, Ashish, as usual, for organizing this. So I'm pretty excited to have Devesh on board, who's going to get us through a lot of the evidence on something that's very critical in the treatment of soft tissue sarcoma. So we have a lot of surgical oncology colleagues with us, and we all know that an overwhelming majority of cancers at some point in time in their cancer career would get radiation. And that's absolutely true even for soft tissue sarcoma, because it has allowed us surgeons to go closer, get safer margins, because our local control rates are being controlled with the use of radiation. So the theme of this session, and the way Devesh is going to do it, is I'm sure he's excited as well. He's going to set up a clinical scenario of a case which he operated right today morning. And he's then going to tell us situations of why is radiation important, how do we know it's important, and assuming that we know it's important, when should we give radiation? Should we give it before surgery, during surgery, after surgery? What are the pros and cons of each approach? Are there situations where it is safe to avoid surgery? And what's the future of radiation in soft tissue sarcoma like? So Devesh, it's all yours. And we'll take them along a journey of evidence in radiation as adjuvant or neoadjuvant therapy in soft tissue sarcoma.
Good evening, everyone.
Dr. Devesh is a surgical oncology resident with us at Tata Memorial. Sorry, Devesh, all yours.
Good evening, everyone. I'm Dr. Devesh from Tata Memorial Hospital. I will be discussing the second part of the adjuvant therapy in soft tissue sarcomas with radiation oncology, with radiation. Before we begin, I'd like to begin with a small case. So this is a 55-year-old lady, postmenopausal, with significant history being she's a case of papillary carcinoma of the thyroid, operated with a total thyroidectomy in 2006. She presented to us with complaints of a right leg swelling since the past 6 months, which have rapidly increased in size over the past 2 months. She was ECOG 0. On examination, there was a 4 into 4 centimeter non-tender, soft, mobile swelling in the anterior lateral compartment of the leg. It was subcutaneous because it was freely mobile and no clinical suspicion of bony involvement. There were no palpable inguinal or popliteal lymph nodes, and there were no distal neurovascular deficits present. So these are the clinical pictures of the patient showing a 4 into 4 centimeter anterolateral mass in the leg. So as we can see, the mass is freely mobile, which rules out clinical bony invasion. And this is the MRI we got. This is a T1 fat suppressed contrast image. As you can see, it is abutting the tibia anterior cortex. It is involving the tibialis anterior. and there seems to be a little tail both medially and laterally. However, both the anterior and the posterior neurovascular bundles are free of tumor. This is the same thing in the SAD section. As you can see, same findings, predominantly subcutaneous and well away from the neurovascular bundle involving the tibialis anterior. So the workup was an NCCT thorax, which showed a 3 millimeter indeterminate lung nodule. The biopsy was a high-grade pleomorphic sarcoma. So now the question, what to do? Now, this shall be the theme of the further presentation. This was the pre-op picture. This was the post-op picture, and this is what we removed. As you can see, this is an intact periosteum, and this is a sliver of the tibialis anterior muscle kept for margin. Over here is the biopsy site, which has been excised with the main specimen with a margin of skin. So to start with, surgery is the mainstay of treatment for all resectable soft tissue sarcomas. The extent of surgery along with the appropriate combination of chemo and radiation is controversial, but there is no controversy regarding the role of radiation. Most cases will require radiation. The opposite is true for chemo, where most cases may or may not require chemo. This will be the outline of what I will be presenting today. I will start with radiation in resectable soft tissue sarcomas, followed by where radiation can safely be avoided, and the role of radiation in previously treated soft tissue sarcomas. So resectable soft tissue sarcomas, firstly, what is the benefit of radiation? And secondly, what are the various modalities of radiation? So the benefit of radiation in the 1970s, around 50% of all soft tissue sarcomas were treated with amputations. Contrast that now to a 1% amputation rate, and with almost no change in overall survival. Combination of radiotherapy with limb salvage reduces the local recurrence by 20 to 25%. However, the overall survival benefit of radiation is a bit doubtful, with 2 RCTs not showing any OS benefit, but the SEER database analysis suggests that there is actually an overall survival benefit. Now, radiation also improves the outcomes after the positive margin. What needs to be known over here is that even with radiation, the recurrence rate after a positive margin is much higher than what it would be if there was a negative margin. So the seminal paper by Rosenberg et al. In 1982 was what established the role of radiation in soft tissue sarcomas. This paper showed that there was no difference in overall survival or disease-free survival between patients who were treated with limb sparing plus radiation or with amputation. It also showed that a patient with a positive margin had a much higher likelihood of a local recurrence compared to those with a negative margin, even if post-op radiation was used. Another paper which cemented the role of radiation was a paper by Williard et al. In 1992, which showed that amputation may improve the local control rate, but this does not affect overall survival. So from 1998 to 2010, a SEER database analysis of stage 3 carcinomas was done. 2,600 patients were found in this, and radiation was shown to have a 5% increase in 5-year survival on univariate analysis for both matched and unmatched cohorts. And on multivariate analysis, this was a 20 to 30% survival analysis for matched and unmatched cohorts, respectively. So now the next benefit of radiation was shown by this study published in the Journal of Clinical Oncology in 1998. It showed that in high-grade lesions, there was a highly significant decrease in local recurrence. There was no difference in overall survival. Now, even in low-grade lesions, there is a decreased likelihood of local recurrence with radiation, but it's not as significant as in high-grade lesions. This is the curve, which shows that there is, in fact, a significant decrease in local recurrence with radiation. However, this study did not show any overall survival benefit of radiation. Another study published in the Annals of Surgery in 2018 for the benefits of radiation towards local control distant metastasis. So there's a 38% relative reduction in the risk of recurrence. There's a strong reduction in the risk of local recurrence with a hazard ratio of 0.42, which is significant. but there is no risk, no decrease in the risk of distant metastasis or overall survival that favors adjuvant radiation. However, if you only take the grade 3 patients, there is an overall survival benefit, which is significant. As you can see from the Kaplan curve, the local recurrence, there is quite a difference, which is significant on the Grace test. However, when you look at the distant metastasis, there seems to be a survival benefit, but that is non-significant. Now, coming to the modalities of radiation, whether to give it before surgery,
I'll request
surgery.
a quick pause.
Sure.
Am I audible?
Yeah, Prakash.
Perfect. So a quick pause. So Devesh has set the tones. So what he's basically covered is, do we know radiation improves local recurrence survival? Absolutely yes. It began in an era where we compared amputation along with limb salvage. Overall survival rates were the same. Of course, we could save many more limbs. And when we use adjuvant radiation, we could have a safe, close negative margin and control local recurrence while giving better function to our patients. There has been debate if a local modality like radiation can really improve or impact overall survival. This has always been controversial, and that answer is still not very evident. Without a doubt, it benefits local recurrence-free survival across all grades, low, intermediate, and high. Of course, the benefit is the most with high-grade sarcomas. The worry, although, when studies used a lot of this post-operative radiation, was the side effects that post-operative radiation had. And then the next stage of this presentation will tell us, how does timing impact a lot of these side effects? Does it impact local control, or is local control the same irrespective of the timing of radiation with regards to surgery? Go for it, Devesh.
So moving on to the modalities, we'll start with neoadjuvant versus adjuvant, followed by brachytherapy, newer modalities such as IMRT, that's intensity modulated radiotherapy, and image-guided radiotherapy, and what is the role of definitive radiation. So now the question, whether to give radiation before or after. The benefits of neoadjuvant are quite a few. Firstly, it's a smaller dose that's given. It's 50 grays, which is delivered in 1.8 to 2 gray fractions over 5 to 6 weeks. It's a smaller field of radiation, and there are fewer delayed, which usually translates to fewer permanent toxicities. Also, the reduction of the tumor burden may allow for a more conservative surgery. And another theoretical benefit is that when you are removing the tumor with intact blood supply, when you are radiating the tumor with intact blood supply, the cells are not hypoxic, and hypoxic cells are radioresistant. So theoretically, radiation given neoadjuvantly should have a better response. Now, adjuvant radiation, in contrast to this, has a higher dose. It's given as a 50 gray with a boost to the tumor bed, which is 10 to 16 gray. This is called a shrinking field technique. A larger field has to be radiated. Now, obviously, there'll be fewer acute wound complications, but the trade-off to this is there'll be more long-term wound complications which are permanent. One of the side effects of neoadjuvant radiation is that there'll be RT artifacts in your histopathology specimen. This will not be there in adjuvant radiation. Also, there's a significantly increased risk of bone fracture in adjuvant radiation. If the bone receives a cumulative radiation dose of more than 40 gray, there's a significant risk of pathological fracture of the bone. And in adjuvant radiation, because the dose is much higher, the risk of fracture increases. So now this is a picture of what could happen with a neoadjuvant radiation. Now, as you can see, there's pigmentation with some skin changes, which looks quite scary. Now, a lot of people would assume that skin changes would translate into wound complications. However, this is not the case. There is no relation between a skin change seen and a wound effect that is developed later on. Now we come to one of the minor trials which evaluated. Yes, sir.
Devesh, one sec. I'll just like to paraphrase what you said. So the key point that Devesh is trying to get at is the worry when we give post-operative radiation is, one, the doses are high. A lot of the normal tissue that's underlying in the body bears the brunt of all this radiation, which means the remaining muscle, the remaining bone, and the remaining joint. Now, we've all seen how radiation-induced side effects, which is a woody edematous leg, contractures, pigmentation in the skin, and late effects like radiation-induced fractures or even radiation-induced sarcoma are irreversible, permanent changes from where there is no coming back. To avoid a lot of these delayed effects, which were permanent, the thought was, one, can we avoid giving all this dose to normal tissue? Instead, focus a lot of this dose on abnormal or tumor tissue. That was the whole logic why people thought, can we give radiation before surgery? Why? Because you have an obvious target in the form of the tumor. The tumor is vascular, and hopefully we'd be able to give the maximum dose to tumor and spare the surrounding normal tissues. And by sparing, we mean giving lesser dose and hopefully expecting lesser long-term toxicity. Now, while Devesh will come to the trial that has compared these two in details, he's starting with an example of one of our patients who had skin pigmentation to neoadjuvant radiation. And what he tried to say is, oftentimes we have two scenarios. One, where the skin will not look like it has received any radiation at all. And two, the picture that you see, where you have significant hyperpigmentation to preoperative radiation. And while intuitively we may think that because there is pigmentation and an ulceration, the wound healing is worse. And in someone where we do not see any changes, the wound healing is going to be better. That's not really the case. Someone who does not show any skin changes will also likely have delayed wound healing, because there is a basic genetic component to how each individual reacts to radiation. And that's the point that Devesh is trying to make. Sorry, Devesh, for that interruption. Please go ahead.
Thank you, sir. So coming to one of the seminal trials that compared neoadjuvant to adjuvant radiation, the SR2 trial, which compared preoperative versus postoperative radiotherapy. It was a randomized controlled trial. In fact, the only phase 3 trial to evaluate the role of neoadjuvant radiation. So as we discussed, acute wound complications were significantly more common in preoperative treatment. That's 35 versus 17%. However, there was more grade 2 to grade 4 late toxicity in postoperative radiation. Now, the median follow-up was 6.9 years. There was no difference in local control, progression-free survival, or overall survival. Another factor that we need to take into consideration is very few wound healing issues popped up in the upper limb. So even in neoadjuvant settings, the upper limb seems to be less likely to develop wound problems, probably because of its better vasculature. So now all the evidence seems to point to the benefit of preoperative radiation. So why would we ever choose postoperative radiation? Now, certain areas are known to have wound healing issues, such as the groin. Giving a preoperative radiation over here would compound these issues and likely make wound healing a problem, causing the patient to be hospitalized for an unnecessarily long duration. So you may consider postoperative radiation in these places. Also, certain subcutaneous tumors like infiltrative subcutaneous myxofibrous sarcomas, which have a very infiltrative diffuse appearance in the preoperative setting, it's difficult to accurately target the preoperative radiation, which makes postoperative radiation slightly easier. Now, there are some patients, I'll come to that later, mainly patients with low-grade small tumors, who you may avoid radiation altogether if the margins are adequate. In these cases, it's better to take a call after the specimen is out and after the final histopathology is ready. Now, in patients known to have wound healing problems, such as obese or diabetic patients, now, one of the fears that we have in orthopedics is if a prosthesis is being used, any wound complication is likely to infect the prosthesis, which is catastrophic because of the morbidity, financial constraints, and other problems. So in cases where prosthesis is used, surgeons may be slightly more hesitant to use neoadjuvant radiation. And in our center, most of the cases we use postoperative radiation because of the logistic difficulty of keeping a patient for preoperative radiation. That completes the segment on neoadjuvant.
Devesh, I'd like to interrupt again. So I want to qualify a couple of statements that Devesh made, and I think we need to give a little more time to understand the nuances of what he said. So what he's established is, without a doubt, while the early complications of preoperative RT are worse, the late complications are worse in postoperative RT. The early complications with preoperative RT are correctable. The late complications with postoperative RT are not correctable. The local control is the same in both. Both have not shown really to impact survival. What this means is for an individual patient, when it comes to the risk of the disease coming back, whether we give radiation before surgery or after surgery, as long as we do good surgery with negative margins, the risk is the same. Essentially then, we are either choosing our patients to have some early complications which are correctable versus late complications which are not correctable. Now remember, a lot of these advantages of pre-operative radiation are with intensity modulated or image guided radiation, where we can truly spare dosing to the surrounding structures. Two, that means you need a dedicated team to plan and deliver therapy. In a center like ours, and that's true for many busy centers across the country and across low and middle income countries in the world, you may not be able to accommodate all of them for preoperative radiation. Number two, you would expect a bigger percentage of your patients who are receiving preoperative radiation to get complications. When they get complications, they will need dressings. They may need plastic surgery as a flap. They may need vacuum assisted closure. They will spend a much longer time in the hospital. Their readmission rates are going to be higher. And all this means a longer time to treatment. And it also means more expense. Remember, the majority of patients in our country pay for the treatment from their pocket. In a busy center like ours, you may not have adequate beds to accommodate for the increased number of readmissions for a lot of these patients. And because of these social logistic factors, it may be better for a lot of our patients to get a negative margin resection, have their wounds healed, and go back to their second tier or villages where they live, where they can get adjuvant radiation at a local center, because that's going to continue for about 6 weeks. Now, it's because of these logistical, social, cost, and other associated factors that many of us may still choose to resort to postoperative therapy, even though in theory, if you look at outcome 10 years from now, preoperative radiation will have its own benefits. And this is the summary of why we do what we do in big centers. Go for it, Devesh.
So coming to brachytherapy, it has many advantages. Firstly, there's a much shorter treatment duration, usually less than 1 week, which in a low dose rate regimen is 45 grays over 4 to 6 days. Everything is completed in one hospitalization. There's an increased delivery of radiation to the tumor bed with less radiation to the surrounding tissues. However, there are no RCTs comparing brachytherapy with conventional EBRT. And also brachytherapy can be used as a boost to EBRT. This is a planning diagram of a brachytherapy. First picture shows the post-operative excision specimen with the tumor bed, and all of these are the brachytherapy needles. So the concept is you need to extend 2 centimeters above craniocaudally and 1 to 2 centimeters laterally. And the distance between the catheters has to be maintained between 1 to 1.5 centimeters. These catheters are afterloaded after the surgery. So now, what are the contraindications for brachytherapy? Now, if the implant or the field geometry doesn't allow adequate coverage of the needles, then obviously you cannot use brachytherapy. If it's in close proximity to a neurovascular structure, you should not keep a needle directly on a vessel. Also, in certain cases, there are logistical difficulties. For example, if the bone is completely exposed, there may be nothing to hold the needles in place and they'll tend to move. So in these cases, it may not be possible logistically to deliver brachytherapy. Now, looking at the evidence for brachytherapy, we'll start with an article published in the Journal of Clinical Oncology, which evaluated the long results of therapy in sarcomas. So now the 5-year local control rate with brachytherapy was significantly higher at 82% compared to 69% in surgery alone. Now the advantage is mainly seen in high-grade sarcomas. There was no advantage seen in low-grade sarcomas, and there was no benefit in overall survival, regardless of whatever the tumor histology was. Now, intensity modulated radiation is a way of delivering radiation to complex tumor geometries where the beam intensity is modulated to deliver a specific dose to an irregularly shaped volume. Ideally, this should be offered to all patients because the complications are less, because the surrounding structures are less likely to be irradiated. And the benefit is obviously that complications will be less. So now comparing I with brachy, this was a trial published in the Cancer Journal in 2011, where even though more of the IMRT group patients had unfavorable features such as close margins or large tumors, the 5-year local control was superior in the IMRT group, which was 92% versus 81% in the brachytherapy group, which was significant. On a multivariate analysis, IMRT was the only predictor of an increased local control. So IMRT is definitely proven to be superior to brachytherapy, but again, as Sir had said, it becomes very difficult to deliver this labor-intensive process to everyone in a high-volume, very busy center in a low to middle-income country. Now, the evidence
one
for
qualification,
IMRT,
Devesh, again, to the brachy session. Now, so we pride ourselves because we have with us Dr. Laskar and Nehal Khanna, and Dr. Laskar really did most of the work for soft tissue sarcoma and pediatric brachytherapy in our institute, and is known globally for the excellent outcome that he's had in brachytherapy. And we're fortunate to have that experience because it gives us a perspective of when is brachytherapy possible and what are its advantages. As Devesh rightly showed, he showed a picture of these brachytherapy tubes. Now remember, after we excise, the radiation oncologists come to the theater. They spend about 20 minutes to an hour planning these wires. They have to be placed at an adequate gap, about 2 centimeters. And they also look at the preoperative MRI and CT images to predict if by putting these brachytherapy wires, they are going to be able to cover the entire volume that must get treatment. So there are 2 limitations that they have when they come to the OR. One, am I going to be able to place these wires uniformly at a uniform gap? That's number 1. Number 2, after I have placed these wires at a uniform gap, am I going to get the dose distribution that is essential to give adequate dose to the entire tumor bed? If the answer is yes to both these questions, they go ahead with brachytherapy. Now, what is the advantage? The advantage is beyond these wires, the dose fall off is absolutely rapid. What that means is, let's say you've got a free flap or a primary closure or a skin graft even on top of these brachytherapy wires. Just a few millimeters beyond or outside of these brachytherapy wires, the dose fall off almost approaches 0. It's called the Bragg peak. The narrowest Bragg peak amongst all modalities of radiation is for brachytherapy. And that's a big advantage because you can really deliver dose exactly where you want to and avoid delivering dose where you don't wish to. Number 2, we use something called a high dose regimen or an HD brachytherapy. What that means is in 2 sessions a day in a complete regimen at with 6 weeks that you would require in the post-operative setting. So there are significant advantages. Now, what are the disadvantages? As Devesh said, the geometry of the defect that the surgeon creates has to be amenable to inserting brachytherapy wires, and the dosing has to be optimal. Now, there have been occasions where the radiation oncologist has put in the wires. They do a CT scan on day 2 to plan their doses. They realize that, well, there is no way we are able to deliver adequate dosing. Either they remove that radiation, or they do HDR brachytherapy for 6 days and then follow it up with external radiation. The only increased risk sometimes is you have to handle these catheters well because they're exposed to the outside. And if they are not handled well, they could be a source of introducing infection into the tumor bed. Number two, you can imagine it's resource intensive. You need the radiation oncologist, sometimes two of them to come to the OR. You need a stock, you need additional OR time. You need them to be admitted in the hospital for about 6 days extra. And all these is logistically intensive and may not be possible, as Devesh said, either in a high volume center or routinely for all patients. These are the main points which encompass the advantages of brachytherapy, where it's possible and where you cannot use it. Go for it.
So now coming to IMRT and IGRT, that's intensity modulated radiotherapy and image guided radiotherapy. So now the incidence of complications is lower in IMRT and IGRT. However, the cross-trial comparison with the SR2 trial, which compared neoadjuvant versus adjuvant, did not reach statistical significance in this study. However, another study which showed that that was published in the Journal of Clinical Oncology in 2015 by Diane, showed there was a significant reduction in the late toxicity. There was 10.5% of patients experiencing grade 2 toxicity versus 37% in patients treated with EBRT. This was significant. And another important point is there were no marginal field recurrences. This is the biggest criticism to IMRT, is that after the tumor, after the dose site, there's a rapid fall off of radiation dose. So the margins are likely to receive a sublethal volume of radiation, which theoretically would increase the risk of marginal field recurrence. This trial showed that there is no marginal field recurrence in IMRT and IGRT. That concludes the modalities of radiation. A small note on definitive radiation. When do we use it? Usually definitive RT is a last resort. It's used in medically inoperable or in patients who amputation is not acceptable. There are some histologies such as myxoid liposarcoma, which are exquisitely sensitive to radiation. The problem with definitive radiation is it requires a very, very high dose. For example, a 3 to 5 centimeter tumor would require a dose in excess of 75 gray. And as you can imagine, that would lead to a significant rate of complications, both acute and chronic. Now, where can radiation be avoided? So there is, as all the evidence has shown, there is definitely a benefit for all high-grade tumors for radiation. What about low-grade tumors? For example, take this case, a 30-year-old female with a 4 centimeter low-grade subcutaneous soft tissue sarcoma of the calf. The MRI showed the neurovascular bundle to be free, non-metastatic on a metastatic evaluation. What are the options available? We could give neoadjuvant radiation followed by surgery. We could give surgery with brachytherapy, or we could just do surgery alone, and based on the final histopathology, decide whether or not the patient requires radiation. Now, is there any evidence to prove to guide what really needs to be done in these patients? There have been attempts to classify this. Well, for example, it has been shown that advantage of brachytherapy is only there in high-risk, high-grade tumors, no advantage in low-grade tumors. Also, high-grade lesions, there's a highly significant decrease in this trial, but low-grade, there was also a decrease in local recurrence. It also showed that there's a significant rate of complications post-radiation. So now the evidence is conflicting. There is definitely a benefit in high-grade, low-grade, whether or not to give is doubtful. So now what this means is there no clear-cut, one-size-fits-all regimen. It needs to be individualized. It depends on the patient, depends on the patient factors. So we need to identify the subset patient by patient. For example, a superficial, low-grade, small tumor will most probably not require radiation. However, a small, purely intramuscular tumor, if you can get an adequate surgical margin, will not require radiation. There have been attempts to create nomograms to calculate the risk of local recurrence. Now, if the risk of local recurrence is high, the patient should receive radiation. One of these is from MSKCC. These are the features which went into forming this nomogram: the age, size, tumor size, margins, grade of the tumor, histology of the tumor. This nomogram was calibrated to get a risk of local recurrence. However, the problem with these nomograms is there's no real cutoff defined as to at what level patient should receive radiation, because these are relatively new and more research on these and probable trials are required to identify at what cutoff a patient would benefit from radiation, where the cost-benefit ratio would be favorable. Another nomogram by Calgaro et al., where she developed the local recurrence using the patient's age, tumor size, and tumor grade. So this again has shown good calibration, but there's no real cutoff to guide when we should start radiation. The second case would be a 68-year-old male, diabetic, high-grade sarcoma.
I take a halt, Devesh. So just to put what you said in perspective, if you go back, see the basic question that Devesh is trying to answer is there a subset where the side effects of radiation overwhelm the benefit of better local control? The one classical instance which Devesh gave was a superficial small tumor that's low grade, where we are able to excise with wide negative margins. What Devesh did not mention, and why he did not mention is because it's controversial, is what is a wide negative margin? Is it 2 millimeters? Is it 1 centimeter? Is it an equivalent of 1 centimeter or 2 centimeter based on the Kawaguchi concept that we've all heard of? It's a big debate and an entire session on its own. We do not yet know in terms of millimeters what's the ideal margin safe enough to avoid radiation. The fact is that in most patients, we will be in the range of millimeters. In the range of millimeters, if it is a high-grade sarcoma, we are better erring on the side of giving radiation than not. On the other hand, if it's a superficial low-grade tumor where we are confidently able to take out a centimeter, and on the final pathology, if you've had adequately wide negative margins all around, we may err on the side of avoiding radiation. Important to note, the benefit of radiation is seen across all grades: low grade, intermediate grade, and high grade. Now, as Devesh mentioned, do we have good data to know in which high-grade sarcomas can we avoid radiation? We do not. There have been some publications from the Japanese and the Italian groups where they have looked at elderly individuals who had excisions of high-grade sarcomas who, because of wound healing or other complications, were not able to receive radiation. And there were many who did not all end up with a local recurrence. And that goes to show that yes, there is a subset in whom we may be able to avoid. Now, to answer that with level 1 evidence, we are going to have a French trial that has begun recruiting 2 years ago. It's a randomized trial specifically in high-grade extremity sarcoma, where they have specifically measured what we mean by negative margin. There is going to be a central histopathology examination so that all margins are reported in the same way. We are hoping to have the results in a few years. It will be a level 1 study specifically for high-grade sarcomas, and it will be able to tell us in which circumstance we may avoid, or it will tell us that it's unsafe to avoid in any of them. So we will look forward to that data. The other important point that Devesh made was he mentioned myxoid liposarcoma. Now, why did he mention this? We get a lot of these questions where if you have a tumor and you give preoperative radiation, are we going to expect that tumor to shrink? Remember, this is non-round cell soft tissue sarcoma. Of course, in Ewing's and rhabdomyosarcoma, which are round cell soft tissue sarcomas, we will have excellent response both to chemotherapy and to radiation. But in non-round cell STS, in most cases, we will not expect the tumor to shrink. There are a few tumors which have exceptional response to preoperative radiation, and myxoid liposarcoma is one of them, where you may get up to 70–80% of the tumor size that shrinks, and which is why preoperative radiation is almost a must in those histologies. Sometimes the response is so good that you may not be able to identify the tumor well on the postoperative MR, in which instance you must fall back on the preoperative MR, take use of preoperative and postoperative ultrasound imaging to know what your adequate margin is going to be. So to answer, we do not yet know where is it safe to avoid radiation. When there is a doubt, it may be better to err on the side of giving radiation than not. Two, most soft tissue sarcomas, your disease will not shrink to radiation. Exception is myxoid liposarcoma. Go for it, Devesh.
Yes, thank you, sir. Now coming to a second case where you have an elderly male with a high-grade sarcoma with 3 indeterminate lung nodules. Now, whether or not these lung nodules are metastasis is doubtful. So do we give neoadjuvant chemoradiation and see if the lung nodules don't progress, then you can proceed with the local therapy? You can proceed with surgery and adjuvant radiation, test, or surgery alone. The idea being, if the patient is going to develop a systemic recurrence before a local recurrence, what is the point of the added morbidity of the local therapy? So now to answer these questions, there have been various studies. For example, the study which showed that patients, there are certain features which make the patient likely to present with a distant metastasis first, such as margins, grading, gender, size, histology, and neoadjuvant treatment. There are factors associated with local recurrence, such as gender, size, neoadjuvant radiation, and margins. So using these, there have been efforts to create a nomogram to see whether, if a patient is going to develop a distant metastasis first, it would not make sense to add unnecessary local morbidity to this patient. The next question we need to answer is in a high volume center where a sarcoma surgeon is operating, where adequate surgical margins are not a problem, is adjuvant radiation mandatory for all patients? Now, this was tried, the answer to this is being attempted at Memorial Sloan Kettering, where 390 patients were identified. The problem with the study is it's a retrospective study, and also the reason for omitting RT was purely based on the discretion of the surgeon. However, they showed that there was no recurrence-free survival benefit in patients with or without RT. Now, obviously, this type of study design has numerous flaws, but it is an interesting concept to see whether a high-grade sarcoma with other adverse features can be avoided radiation. Now, previously treated sarcomas, there are two things over here. Most of the times, there will be a sarcoma which is treated outside by accident. People assume it's a lipoma or some benign swelling and excise it. And when the histopathology comes, it's a big whoops for everyone because it turns out to be a malignancy, positive margin. Sometimes there are piecemeal excisions, and these patients are referred to a sarcoma center for further management. What to do in these settings? And also in a patient who had previously treated for the sarcoma with radiation, when he develops a recurrence, a local recurrence, how do we manage this patient? Do we re-irradiate him? If so, what is the evidence to guide this? Now, assuming there's a patient, a 42-year-old man with a pathology came back as a synovial cell sarcoma, the key take-home message over here is the margins were free and the specimen is removed in a single piece, which means the specimen was not violated, assuming there's no tumor contamination in the field. Postoperative MRI shows only postoperative changes. So now what? Do we observe the patient? Do we excise the tumor bed, or do we radiate? This is a question for which there is no right answer and there is no wrong answer, luckily. All three are acceptable because this is a sort of vague case. Assuming any one of these features was not there, assuming that the histopathology had multiple sections of tumor, meaning that the tumor was violated intraoperatively, assuming a margin was positive, assuming it was high grade with high risk features with involvement of a margin, those cases definitely would require re-excision or radiation. However, in a favorable case like this, the doubt arises.
So Devesh, I'd like to counter your claims there. So a couple of factors to remember. One is an unplanned excision is an unplanned excision. Oftentimes, the rule is that yes, you would go back to the surgeon and ask them if they suspected this to be a sarcoma or not. Now, if clearly they did not suspect this to be a sarcoma, you would suspect if their concept of negative margin is clear or not. Oftentimes in an instance like this, as you said, the postoperative margins are free. You then have to realize if you can re-evaluate those margins. Oftentimes you may not be able to. Two, you have to know what was the extent of those margins. And three, it's important to know the location of this tumor. Remember, there was a long and excellent study from the Sloan Kettering group published about 10 years ago, where they wanted to know in re-excision, in all WOOPs excisions, what happens when you've not seen tumor in the preoperative MR, right? So you've given us two situations. One is someone has had a WOOPs excision, they come back with an MRI, the MRI does not show disease, the pathology specimen reporting says the margins are clear, but it was an unplanned excision done by a surgeon who did not think he or she was excising a sarcoma. What should we do? Should we do a tumor bed excision? Just give radiation? Just observe? In that long-term study, up to 30% of patients who did not have any visible tumor on the preoperative MRI after a WOOPs excision ended up having microscopic tumor cells in the tumor bed. Now, what that means is even though our ultrasound and an MRI is negative in an unplanned excision, we may still see microscopic tumor cells in up to 1/3 of these cases. So in the ideal world, doing a tumor bed excision in everyone would likely give them the best chance of optimal local control. But we have to add another factor, is how soon after surgery did they come to you? If they came to you within a week versus if they came to you after 6 months versus if they came to you after 2 years, would your recommendation be any different? As you said, the maximum risk of local recurrence is in the first 2 years. Many centers would claim that if the patient comes within 2 years, we may offer them tumor bed excision. Having said that, practically what most centers end up doing is if there is a delay of beyond 4 to 6 months from the WOOPs excision, and if the MRI and the ultrasound are not showing any residual tumor, you may do active surveillance, keep them on a close follow-up, let the local recurrence manifest itself, and then go ahead and treat it based on its merit. If they have come with a negative margin excision to you, the wound has healed well, and you do not see any tumor on the postoperative MR, yes, you would advise them adjuvant RT. If any of these factors are absent, you would advise them a tumor bed excision. Now remember, if the tumor bed excision is extremely morbid or it's impossible to know the extent of contamination from the earlier surgery, oftentimes you're forced to resort to observation with or without radiation. So as you said, it's going to depend a lot on the grade, the surgeon who operated, the location on the individual where it was operated, and the timing after the WOOPs excision when they present to you. And it's a combination of all of these which will make you decide which of the three you're going to offer. Tumor bed excision will likely be the safest, but yes, it may be more aggressive, and maybe there are a few patients in whom you can spare this tumor bed excision. It's tough to know in whom it's ideal to spare. So before you proceed, I want to answer a question that's been put up on the group. What about low-grade extremity liposarcoma? I must qualify that extremity well-differentiated liposarcoma must be renamed and is already renamed as an atypical lipoma. It behaves like a benign tumor. It has the risk of local recurrence. It has close to zero risk of distant metastasis. So an extremity well-differentiated liposarcoma must be called an atypical lipoma to convey its low risk. You remove it with a marginal margin. you do not have to use any radiation. If there is a high-grade dedifferentiated liposarcoma, then it is treated like any other high-grade soft tissue sarcoma. Okay. There's another very interesting question from one of our colleagues, Vivek Verma. I assume it's Vivek Verma who was with us at TMH. He's got an interesting question, which is, what's the consensus? Should we use brachytherapy alone, or should we add external beam radiation along with brachytherapy? The conventional initial papers of brachytherapy always use a boost at the end of brachytherapy. Now, more and more evidence from centers that do brachytherapy, high dose regimen or HDR brachytherapy alone is good enough for most cases. If on the planning CT or the planning MRI, the radiation oncologists find that there is some area which is underdosed at the end of the brachytherapy, they may choose to add a boost in the form of teletherapy at the end of brachy. In the overwhelming majority of cases, HDR brachy alone is sufficient. Go for it, Devesh.
Yes. So moving on. So a 50-year-old male with a recurrent swelling over the thigh. Previous excision showed a high-grade clear cell sarcoma. He was operated 5 years ago with a clear cell sarcoma, high-grade, margins-free. Post-op, he received 66 grays of adjuvant radiation. Metastatic workup is negative. MRI shows a 5 to 6 centimeter mass involving the quadriceps and adductor muscles, but the neurovascular bundle is free. So what to do over here with regards to radiation? The patient is already irradiated once 5 years ago. How do we proceed? Now, the evidence for this is patchy. So now in a locally recurrent soft tissue sarcoma, what to do? An article published in the International Journal of Radiation Oncology in 2007 of 62 consecutive patients. So the local control was only around 50 to 51%, and a positive margin was associated with a lower rate of local control. Now, re-irradiation did not improve the local control in this study. However, the complications associated with re-irradiation were quite significant, with 80% of them developing complications versus 17% without radiation. Also, the amputation rate was much higher, more than 3 times higher in the re-irradiation group of patients, which was statistically significant. However, a conflicting study, another study performed in 1996, published in Radiotherapy. So in this study, 25 patients treated with a locally recurrent soft tissue sarcoma with either just surgery or irradiation. So local control was significantly higher in patients with re-irradiation. All 10 patients treated with radiation had a local control versus just 36% of patients treated with just surgery. Now, there was 60% of these patients experienced significant post-irradiation wound healing complications, but 70% of those patients had a good long-term outcome with a good post-treatment functional score. So the take-home message from this study is a combined conservative surgery and re-irradiation provides a superior local control to just re-excision alone. So now this is somewhat a gray area, but most people would believe that re-irradiation is of benefit to the patient. It does, in fact, reduce the local recurrence rate, and the only trade-off would be that there are complications. So now the methods to reduce the complications, you can either give radiotherapy intraoperatively, you can either give brachytherapy, or you can give proton beam therapy, which has a very rapid fall off. So there's no radiation of the neighboring structures. So a few studies comparing these things. So now in brachytherapy in patients with resection. Yes, sir.
Sorry, just one qualification on the last slide. So I just want to give a perspective that there virtually was just one center in the world at Mass General that had the ability to give intraoperative RT. The overwhelming majority of the world today either do not have the ability to give intraoperative RT, and there is not enough financial and oncologic benefit to the investment that you need for intraoperative RT. So you're very right in concluding that re-irradiation should be considered in every patient who's received prior irradiation. There may be a benefit in local control. Yes, the cost is higher, radiation-induced side effects, and the way to reduce this currently across the world would still be to give IMRT, IGRT, because that's most prevalent. In the future, we may have particle therapy, which may reduce the side effects with improved radiobiologic effects, and that includes proton and carbon ion, but we are many years from making it universally available to the overwhelming majority of patients. So IORT and brachytherapy is in a very small setting. Particle therapy may come up in future.
Thank you, sir. So a little bit of the evidence regarding brachytherapy. So in this retrospective study published in 1999, complications occurred in 5 out of 26 patients, 4 of whom required a surgical re-exploration. The local control was 52% with an overall survival of 52%. This is again in favor, in line of what the first study had shown. So this is this study Sir was talking about, where intraoperative radiotherapy in fact does reduce the risk of long-term complications, but it is a bit difficult to deliver and labor intensive, resource intensive, not applicable to majority of the population. So this would be all the evidence that I'll be presenting. For the benefit of the surgical oncology people who are listening, I'd like to quickly go over a few of the recommendations made by the NCCN. But this is a brief summary of the soft tissue sarcoma extremity of the NCCN, where stage 1 is grade 1 tumors with no mets. Stage 2 is grade A tumors with small tumors, that's T1. Stage 3 is high grade T2, T3, T4, and stage 4 is either nodal or metastatic disease. So now when we are dealing with a stage 1 disease, that's a low grade, if appropriate surgical margin is possible, we do not really require radiation. This is a summary of what I have said before, but just for completion's sake. However, if an appropriate margin is not possible, re-resection is definitely recommended because that provides far better outcomes than radiation. However, if re-resection is not possible, you can consider radiation or observation if the tumor is stage 1. Now, in stage 2 tumors, that is a high-grade T1 tumor, if it's possible to resect with a good functional outcome, you can go ahead with the resection, or you can give preoperative radiation. If you go ahead with the resection and the margins are fine, you can, the word is can, avoid radiation altogether. But it again, there's no firm evidence to support or deny whether radiation is beneficial in this group of patients. In stage 3 patients, that is high-grade large tumors, it's better to give neoadjuvant radiation. If not possible, at least adjuvant radiation. Now, in unresectable tumors, you can give neoadjuvant radiation, neoadjuvant chemoradiation, or go with an upfront amputation. After the neoadjuvant treatment, if the resection becomes possible, go for it. Otherwise, an amputation. If it's an unresectable disease, patient becomes best supportive care and should be referred for the same. This is the same thing given in DeVita, where the same question that was asked earlier. If a patient has a well-differentiated liposarcoma, which is a low-grade superficial tumor, liposarcomas are atypical lipomas. They do not require any adjuvant or neoadjuvant treatment. So complete excision with no adjuvant treatment. However, all other histology types, if the margin is negative, you can not give radiation or adjuvant treatment. If the margin is positive, it's better to give adjuvant radiation. For high-grade tumors, if it is Ewing's or rhabdomyosarcoma, that is a topic altogether different. They will require a neoadjuvant treatment. We will not be touching on that. However, other sarcoma types, you can proceed with a function-sparing excision with post-operative radiation. If the margins are more than 5 centimeters, definitely. If the margins are less than 5 centimeters, you can decide on whether to give neoadjuvant radiation depending on the other factors of the patient. That will be all. Thank you for your patience.
Great. Devesh, so 3 points that I would like to add from the excellent presentation that Devesh has made. One is, do we have any trial that's going to answer this question of Devesh mentioned? When we give postoperative radiation from the edge of the tumor, the conventional teaching is you would go about 3 to 5 centimeters longitudinal, 1 to 2 centimeters around the width of the tumor and cover all of that area in the postoperative radiation fields. Now, the question that surgeons and radiation oncologists have is, can that area be lesser, which means it will be lesser dose or lesser radiation to normal tissues without affecting local control. And now we have an excellent trial whose results will be out soon called the Vortex trial, which is tried to reduce the dimensions from 2 to 1 centimeter circumferentially around the margins of the resected tumor in the postoperative setting. And that will tell us if lesser dose and lesser volume will still be good enough for equivalent local control. The other question is, let's say I'm giving preoperative radiation. Sometimes the tumor may undergo a cystic necrosis and increase in size. Sometimes, like in myxoid liposarcoma, the tumor may shrink to half its initial size in 4 to 5 weeks. Does that mean I continue to give radiation to the same field and the same dose? The answer is no. We may be able to change both the dose and the field, and that's called dynamic adaptive radiation. There are trials going on this, and in the coming 5 years, when IMRT and IGRT will be uniformly used, we may be able to use data from these trials to know in whom should we increase dose and size, in whom can we decrease dose and size, particularly for tumors like myxoid liposarcoma. Lastly, can radiation in soft tissue sarcoma be used to improve the effectiveness of targeted therapy? We use trabectedin, we use pazopanib, we use many other drugs in soft tissue sarcoma. And there are some studies going on where you give a short dose of radiation to the tumor, cause a little cell lysis. What this does is it exposes the intracellular antigens to the circulation and uncovers antigens in the blood that were hitherto not accessible to drugs, so that drugs can then act on that tumor. It's something like using an abscopal effect, except it's being used locally. And studies are going on in soft tissue sarcoma, in chordoma, and some other disorders where we'll be able to use this modality in future. So these are amongst the 3 things that, so an excellent question that's come up about radiosensitizers. It's a great question because in the last couple of years, there have been many phase 1 and 2 studies that have been published where we are working on using drugs like trabectedin, using mTOR inhibitors, and the most effective modality that I think was also published in Nature was using nanoparticles to use as radiosensitizers for radiation in soft tissue sarcoma. There has been excellent outcome in phase 1 studies using nanoparticles as radiation sensitizers, and phase 2 or combined phase 2-3 studies would be starting in the coming 2 to 3 years. So the answer is yes, radiation sensitizers are being actively studied in the field of soft tissue sarcoma. So I just saw that question come up, and thank you, Devesh, for that excellent and comprehensive turn of events. Ashish, any questions? Anything else we have missed? Something we should?
Yeah. So Devesh, congratulations for a clean presentation, and I think you have compiled the literature very nicely. And thanks to Prakash for sort of summarizing the things in between. A few points. Radiosensitizer is something which we need to explore a bit, and as Prakash already mentioned, that we have a lot of trials going on, and because the whole aim when we look at radiotherapy is to decrease the toxicity and radiate smaller fields as much as possible, being more accurate and have the same outcomes. On the same lines, like we are looking at a lot of radiosensitizers. I think there was already a discussion about using heavy ion therapies like proton beam therapy and and carbon ion therapies. So those are also the answers where you can give very precise high dose of radiation. But at present, all this is under a trial setting and not into use. Other comment which I would like to make is that the use of brachytherapy. See, what we need to understand is that we cannot have a head-to-head comparison of brachytherapy versus other external beam modalities, because as Prakash also mentioned, and he shared our experience from Tata Hospital, that there have been about 30 to 40% of the time when the bed is not suitable for brachytherapy, so there is an inherent bias in case selection when you talk about brachytherapy. Brachytherapy is a fantastic answer for pediatric age group and superficial tumors. Even if you are doing flaps, it is very good. It is fantastic in cases where we are doing scar excisions of unplanned WOOPS procedures done earlier. But we cannot have a head-to-head comparison because in large deep-seated tumors where your cavity is uneven and we do not have adequate musculature, or the area is not even to give a uniform dose of radiation, brachytherapy won't work. So hence, though people have tried to compare it, but I think it doesn't match as the case selection is different. But yes, brachytherapy has its own advantages, and if used judiciously in rightly indicated cases, it is fantastic. It is very good, and that's what we published as well. Other point which I would like to highlight here is, and the question also popped up on the screen regarding preoperative CTRT. So the point which I want to highlight is the combining both the adjuvant therapies. That is something which is again area which is being explored more and more. The reservation for combining the therapies was increasing toxicity, and but now we are trying to use lower dose of radiation and combining them with neoadjuvant therapy, especially in areas which are distal to the knee and an elbow, where the toxicity levels can be managed well. So we avoid in the proximal sites. So that is one area which is coming up, but yes, it is used. There always been debate discussing about the use of either preoperative radiotherapy or preoperative chemotherapy in borderline resectable cases. I think we touched upon that in our previous presentation when we were speaking about adjuvant chemotherapy. So again, it will depend upon histopathology, and I think we discussed that if it is a round cell tumor, then definitely you will use preoperative chemotherapy. But like synovial sarcoma or other high-grade sarcoma, if you have to use preoperative adjuvant, then you will use radiotherapy. So these are somebody is shouting from George's house. Anyways, so that was few points which I want to highlight. And I think as far as the exam is concerned for the residents, I think you need to look at the scenarios. You need to look at the comparison and advantage and disadvantage of preoperative versus postoperative radiotherapy, combination of therapies, when it can be used and how it's to be used, different use of brachy and external beam therapies. So I think these are the common questions and the principles of various type of therapies which comes. So I think we have more or less summarized it all. And I think Prakash also mentioned you earlier that initially, and the data till now suggest that radiotherapy is very effective and is must for having a good local control. That means we have adequate evidence, unequivocal evidence to say that if we add radiotherapy, it definitely decreases the rate of local recurrences. Whether it converts into a better overall survival, it is still debatable. There are a few recent studies which talks about improving the overall survival, but what we need to understand is that we also need to look at whether these cases were multiply recurrent and what were the histopathologies and the metastatic stage at presentation. So that there are multiple confounding factors which makes it difficult to get the data out. And obviously you require a very long follow-up to get those results. So I think these are the comments from my side. And what I would also like to highlight here is that we have missed on one presentation, which was basically the case presentation regarding the soft tissue sarcoma lesion, which was supposed to happen today, but we thought we'll cover in this class. You can send your queries to this number and we'll try to address them as well. You know, it has happened as a coincidence that that tomorrow morning 10 a.m. I'll be taking online classes for Association of Surgeons of India, the Telangana chapter, and they'll be presenting cases on soft tissue sarcoma. They have extremity sarcoma, retroperitoneal, and maybe a bony sarcoma. So these are the details which I want to share with the people who are interested and who feel that they want to log in. I'll share the details with you. In addition to that, as suggested by my colleagues and my team in Tata, that we need to have compilation of all these recordings of all these classes. So we have, so I have initiated this YouTube port, which is by name Orthopedic Oncology Classes by Ashish Gulia, and we will have these recordings uploaded onto this YouTube channel. We are trying to upload them one by one. So hopefully, you know, from tomorrow onwards, you will start getting this compilation, and slowly over the time we will increase this library, and I think it will be a good asset for everyone to have a look at it, and we can have multiple sort of classes and videos in it, including the examination videos. We can have some discussion chats as well. So we will explore this more, but I think this was one news which I wanted to share from my side. So I think thanks a lot, and we will be happy to take any questions if there are any. Devesh, any questions?
No, sir.
Okay, Shrinath, you got any questions? Any additional queries?
None so far, sir.
Okay, great. And let me check. And Shrinath has posted the channel details as well. So I think it will be a nice compilation of these classes. So once again, so that brings us to end of this class. Thank you much. Thank you so much, everyone, for joining in. And special thanks to Devesh for making a nice presentation, and my entire team at Tata Memorial Hospital. These boys have done fantastic work, and they have been actually the backbone of you know, all these classes and doing the arrangements. Thanks to Dr. Ashok Sham for providing the platform of Ortho TV and telling us that we can reach you know, many people, and many people can get benefited. Thanks to Dr. Nayak for moderating it so nicely. And I hope we will arrange more classes if this lockdown continues, and we'll keep sharing the details with you. Thank you so much.